15th Summer of Healthy Living. I'm Mike Powers. I'll be introducing tonight's speaker. As a reminder, and as I look at both, especially the Tsigonis family, the hospital and the university connections, it's really amazing what Michelle Bartlett has done. Last night there was a lecture with Margot Class who talked about her bookbinding, and the place was maybe twice this attendance. And it was her birthday, and the whole place said happy birthday to her. It was really a sweet, genuine endorsement of what she's done in order to pulling the university and the medical community together. And I've mentioned this before, but I think of William Wood, who was the first president of the Hospital Foundation. I think of Harry Porter and Bill Mendenhall and Con Frank and labor organizer Corn Fine, and I think of in the Tsigonis family, the Jack Wilburds and Bert Bells, and this incredible group that ties the university and the medical community together. And here we have Dr. Abe Tsigonis speaking tonight. But also, next week we'll have Kari Burrell, who spent a year essentially, or 5 years essentially as chief of staff up here, and now is the chief strategy officer at the foundation, the hospital, and so that should be an interesting session. We also, I was just talking to Bill about AI and the study of what healthcare should look like in an insular community like Fairbanks. That's coming up too, so there's some great talks. But as I look at what Michelle has put together, and I just want to mention this for all of you, those who have special interests, for camps for adults, bicycle maintenance and repair, botanical drawing, the early season and the late season, introduction to mycology and the mushrooms in the fall, pickleball, golf, painting like Cindy Lawrence, street photography, great stuff with some names you would recognize. And then for those who have grandkids, these kids camps are amazing. Dinosaur camp, drone camp, entomology camp, crazy cool concepts in calculus camp, French camp, Japanese camp, Shakespeare camp. It goes on and on and on. And I just encourage you to take advantage and use this book through the summers. It's just amazing what Michelle has done to pull the whole community together. This Thursday, there will be the Music in the Garden is the Juneteenth Gospel Choir at 6, Clarence Pate Project at 7:30 with Willie Blackburn. Looking ahead to Healthy Living next week will be, as I mentioned, Dr. Stephen Heffington, FMH Medical Director, and Kari Burrell, former Vice Chancellor here, now Chief of Staff at FMH. But with that, let me introduce tonight's speaker related to Healthy Living Lecture. Dr. Abe Tsigonis comes from as you know, a very well-known and highly respected Fairbanks family, and the tentacles are deep within this community. General surgeon, so Dr. Tsigonis has been here, we'll say 10 years or so. One of the very first years he was here, I think the first year, I'm walking down the hall and Dr. Bill Montano grabs me and he says, "That's Tsigonis, he is really good." And I never mentioned that to you, but I should. He is drawn to general surgery, especially because of the instant impact, the improvements to the quality of life academically. Went through the University of Washington School of Medicine, through the WWAMI program, which has had an incredible impact here in Fairbanks and across Alaska. Residency at the Gunderson Health System in La Crosse, board certified by the American Board of Surgeons, fellow of the American College of Surgeons, Gunderson Health Associate Faculty, Pacific Northwest University faculty. Let me introduce Dr. Abe Tsigonis with Foundation Health Partners, who will be speaking on advances in minimally invasive surgery, faster recovery, and better outcomes.
Thank you. I appreciate the honor of the podium, Mike, and the privilege to get to talk to a lot of people that I know that watched me grow up, and hopefully get to talk about something that's educational today, learn something, and then you can pick my brain to dive us deeper than what we've already got up here. I knew that it was going to be a really, diverse crowd, right? Lots of different backgrounds, some medical, a lot not medical. And so trying to make it approachable and good for everybody, but please feel free to help take it where you were hoping that it would go too. So I guess let's go put the slides up, please, sir. Thanks. So the first slide is just going to be my disclosure. I think we've already kind of talked about that. I'm a surgeon. And so, sorry, and there you go. Yeah. I am not paid by any device reps or companies or whatever. I don't get any stipends from them. I do make a living doing everything I'm going to talk to you about. And so there is potential bias there. But hopefully I'll, in another slide, explain why that bias is hopefully negated. But then I think the next thing is that I'm showing some images. Most of them are cartoons and sketches and whatever, but there are some real medical photos, so used with permission. But if you don't want to look, close your eyes. There you go. So those are my disclosures. So we'll talk a little bit about surgical history, because you can't make it through surgical training without being pimped on a whole bunch of old dead surgeons and their names and what they accomplished, what they did, and then kind of how that all applies to life. We'll talk about what is MIS, or minimally invasive surgery. Talk about outcomes, because that is a big deal, right? And we'll talk about how outcomes matter differently, but really closely related for the patients versus the providers versus like a hospital versus payer systems like CMS. They want to know different kinds of outcomes, different kinds of quality, and figure how that all applies to us. And ultimately, I think the goal is all similar, but not always quite the same for where we're going in healthcare. We'll use some really common examples, because that's what I do as a general surgeon. So gallbladders and appendix, we'll talk about those primarily. And then at the end, we'll talk about where cool stuff is going with colorectal surgery, breast surgery, and then we'll be done. So Mike kind of took this slide's thunder. Born and raised here, a lot of you know that. The family came in 1913, so we've been here a long time. Got lots of different family-owned and run businesses and things going, still going. I was Fairbanks Montessori, then homeschool, and then a year at Tanana, Lathrop, UAF, so I got a chemistry degree here. I started in this building. Thought I was going to do engineering, and then flipped after first year, so I wasn't sure kind of what I was doing, but anyway, I ended up with a chemistry degree. And then went to UW. I was the first Alaska second-generation student, because Mom was there too. And then ended up in La Crosse, Wisconsin at Gunderson Clinic, which was a perfect match. And I, like everybody who lives here, I think, wants excellent health care. I don't want to have to leave to get it. I want to feel comfortable that my family can get it here. And so that definitely is a passion of mine, that I want access for everybody. So hopefully that comes through, and it's been demonstrated in the first part of the career. I like to think I'm a young doctor still. I am starting my 10th year in practice, like Mike said, and so hopefully have another couple decades worth of good practice here, and then get to retire and do something else. So historically, when you think minimally invasive surgery, you don't necessarily, the first image is usually, I think, thinking kind of traditional surgery, right? And you don't really think about things. So this is me I'm in the green hat, but the last day of residency. And I got to do a really cool case with Tom Cogbill, who now is actually passed. He passed a couple years ago, so the guy in the middle. And an excellent surgeon. He was a trauma vascular guy, well published, well respected, was president of the American Board of Surgery, certified generations of surgeons. And one of the first things he taught, he did the trauma lab and teaching us how to get in quick, how to stop bleeding. And he said, never be afraid of making a bigger cut. He goes, nobody died from a bigger incision. They'll die if you don't fix the problem. So I think that's kind of the counter to what we're talking about today, is make a big hole if you need a big hole. But hopefully you don't have to make a big hole to go in there. There it goes. Yeah, so this is that same case. It's us sitting there. Traditional OR, right? So big room, bright lights, patient laid out. Tools are the traditional kind of, let's see if the light works. Yeah, it does, yeah. So, handheld instruments that are going to be put into a patient. And we're doing this through a, traditional kind of top to bottom laparotomy. So here's the real picture if you don't want to look. But this is an example of us maximally invasive. You could also call this, single incision surgery. That's pretty cute, if you want to call it that, but it's one big cut, right? And so sometimes you have to do this. Some surgeries have to do this, but a lot of times we don't. So surgery has moved over time, right? From the traditional full laparotomy, like the left side of the screen shows, to as you get maybe more comfortable with your own skills as a surgeon, but then also as technology develops, you can go to maybe 2/3 of the belly. Then you can go to maybe 1/3 of the belly and do the same surgery through it. We can, then as that has progressed, we've got to multi-port laparoscopy. So multi-port laparoscopy is what this upper image shows. So kind of 3 or 4 or 5 small incisions that are going in to do whatever number of surgery. And this is not necessarily just general, but gynecology and thoracic surgeons and that kind of stuff all use the same kind of instruments. And then we said, hey, can we do the same thing through single incision? So we got single port laparoscopy. So a bigger single spot, but then you can put 3 or 4 instruments through one hole. So we'll talk about that. So minimally invasive, what does it mean? I think that is a moving target. It's been moving with time, right? So I think that we started with laparotomy, and then this used to be minimally invasive, doing it through a 5 centimeter incision, but that's no longer considered minimally invasive. This is, but I think even in my career, in the talk, you'll see that it's getting smaller and smaller and smaller because it helps people. So I want to talk about what is laparoscopy, because I realize that might not be obvious. Maybe it is obvious, but laparoscopy is looking into the abdominal cavity or the peritoneal cavity with a camera. We use the same technology to look at joints. That's considered arthroscopy, though. So same kind of camera, but small and looking in the joint. If you look in the chest, it's thoracoscopy. So what I do as a general surgeon is primarily in the belly, although we don't have thoracic in town. So if you come in and you've punctured a lung and you're in our ER, you might get me going in your chest too. But that most often general surgeons are in the belly. Originally, laparoscopy, there wasn't video technology at the same time that the lenses were invented, right? So the surgeon was the only one that got to see what was going on inside. They'd put their eyeball on the laparoscope and be looking in there, and the assistant had a really hard time assisting and telling you what, because they said move left, and they're like, my left, your left, patient left, what's going on? And so now, though, obviously we got nice cameras. It's on the screen. Everybody gets to see what's going inside. You can take pictures for the patient. You can record the case. You'll get to see an example of a recorded case that I got to help do. And then we have instruments. So traditional laparoscopic instruments, sorry, don't walk that way, are straight. They're long. They go through our access ports. They usually have 2 degrees of freedom. We can spin them in a circle, and then we can open and shut them. They provided a lot of good surgery, but we'll talk about how that's maybe not the best that's out there and other ways we can go. So outcomes, man, it's like you can go so many different ways, and we can talk, a whole day, or they make whole week seminars about surgical quality, patient care quality, right? And so you can talk about just this and patient outcomes. But I think that when we're talking about surgery, I put just a few highlights on the slide. The first one is, how long am I going to be in the hospital, doc, right? That's the first thing that the patient asks me when I'm doing clinic. And then how long is the surgery going to take? And how long until I get back to normal life? When can I start doing what I want to do? Run, bike, hike, or just get back to work? I'm a mechanic at whatever store or place. So time is really important for one of the outcomes for patients. Time is also important to the hospital, because the time you're in the operating room costs money, right? The more you can do makes money, and so they want to make you efficient at what you're doing and going. And then beds. We only have so many beds. We've been near capacity a lot this year, and so you want to get people in and get them out so that you can get a new patient in and not be on divert. You don't want to be able to say, hey, we're full, sorry, you got to go to Anchorage to get whatever you need done. So time is important. Pain, is a big deal when you're somebody who's creating pain, right, as a surgeon, right? So I'm going to make a wound that then has to heal on you. And so patients want to know how much it's going to hurt. They're going to know what you're going to do to try to prevent the hurt. And maybe you can totally avoid the hurt by doing a procedure differently, kind of thing. So that's one goal. Those are all relatively short term, but then we deal with a lot of stuff like cancer that has more of a am I gonna live 5 years? Am I gonna live 10 years? And then are you gonna be able to tweak something that's gonna change that 5-year survival from 80% to 85%? And so I think that is a huge outcome measure that everybody's excited about, but really the patients are the most excited about, right? They want you to provide the most long-term life that you can and quality life that you can. The hard part about that is you need long-term studies, right? You make a little tweak today, you might not know for 15 or 20 years, did it make a difference in the outcome of this kind of thing? So those are harder to study, but they are really important. Most of us live here, don't necessarily want to leave here, and so can we do it close to home, or do we not have the ability? And so I think it's important to know, as the providers, your limits, what's appropriate, what's not appropriate, and then help educate patients to end up in the right spot for them. And then those are all kind of the positive outcomes are on the top of the slide of like things that we want to make good and we want to have happen. This stuff in this kind of second to last bullet is all the stuff that you don't want to have happen, but it's important to know what are the rates of all the bad things. The post-operative heart attack, the post-operative pneumonia, the post-operative stroke, the wound healing problems, wound infections, or just wound dehiscence where something falls apart, doesn't heal. You want to know those things and try to minimize them, because that's also providing quality by not having problems as well as having good things happen to people. And so FMH, I think, I should know the year we started, but I think we're on our third or fourth year now being part of the National Surgical Quality Improvement Program, or NSQIP. So it was started by the VA, and now it's part of the American College of Surgeons, but it's one of the risk stratified quality programs to help us know how we're doing. And so it stratifies, a lot of it's always, you never feel like it's your fault, right, as the person, because you're always trying hard. You don't think, they got a wound infection because I did something wrong. And you always have potentially an excuse as a provider, right? Like, my patients more of them are smokers, more of them are diabetics, more of them are whatever, name the problem, and that's why I'm having complications. It's not because I'm doing anything wrong. Well, this takes all that into effect, right? So the quality nurse puts in smoker, diabetic, overweight, wound infection, and then they compare me at FMH, which is the 170 some bed hospital, to other 170 bed hospitals across the country and world, and they say, you know what? Even though your patients are so sick, you're doing worse than everybody else, and you got to work on it. And so it's been a real good eye-opener, because I think that it goes both ways. One time, you get complaints, and you're like, man, we're doing bad. What the heck? And then you can look at it, you go, you know what? We weren't doing bad in that. We had some complaints, but actually we're top tier in the country. So hey, we're doing okay. And vice versa, where you thought you were doing great, and you're like, uh-oh, we're not doing so good on that. We got to work on it. So that's helped, and it helps reassure providers, patients, CEOs, but it also provides a tool to help educate. So this is a snapshot of 3 of our columns. I tried to be really benign. I didn't ask for permission to show this, so hopefully I don't get in trouble. But this just shows where we're average in a couple of the metrics. So we got a whole bunch of, the data sheet is ginormous, but it shows that this is general surgery, that's why it's called general, so unplanned intubation. So if we take you to surgery, we have a breathing tube in, we complete your surgery, we get the breathing tube out, now you're back up on the floor and recovering. If we didn't think that you were going to need to be re-intubated, and you end up getting re-intubated because something happened, you decompensated, didn't do well, et cetera, then that would be one of those fallouts. And this said that out of 528 cases in the previous, this is all like 18 months behind time. It takes a while for the data to get into the system and then to get reported kind of thing. But there was 2 unplanned readmissions, which is as expected. So we're kind of average for that. And similar for somebody on the ventilator for more than 48 hours, we're at average for that. And for venous thromboembolism, so that's having a clot form after surgery, which we don't want to have happen, we're at average, as expected for that at FHP. So this is kind of our real data. So this is kind of cool stuff. This is real outcomes. It matters. It makes a difference to everybody, right? Okay, so I'm going to talk about gallbladder, and I realized that I can't talk about how I fix it unless I know everybody knows what it is and what goes wrong and that kind of stuff. So I'm just gonna do some basic med school, and then we'll go into surgery. So the gallbladder is an organ that is in the right upper quadrant. It is part of the biliary tree, so the bile ducts kind of look like they're in the shape of a tree. So the liver is obviously a big organ, also in the right upper quadrant, and it makes bile all the time. It doesn't know when you're eating, when you're not. It just is making bile. And but if you're not eating, there's a hormone response down at the sphincter of Oddi, which is a little muscle down here at the bottom of the bile duct that squeezes shut. And so that bile kind of backs up into the common bile duct and through the cystic duct into the gallbladder, and it's just a storage tank. So it just passively fills when you're not eating. And then when you do eat, that muscle at the bottom relaxes, and the gallbladder is supposed to squeeze and squirt that bile out. Bile's purpose is really like a saponifying agent kind of thing. It helps to dissolve fat to help us then utilize that better with absorption and the vitamins that come with it, like vitamins A, D, E, and K. So that is kind of the purpose of the storage, the gallbladder. It's a storage tank. It's to the side, and because of that, it's actually not necessary to have it. You can just get rid of the storage tank, and as long as the main bile ducts are intact, you're still making bile. Bile will still come in, but you won't get a bolus of it. So there can be some side effects from it being a slightly altered anatomy, but really in the long run, you don't have to have a gallbladder. So the most common problem with a gallbladder is gallbladder stones. There's kind of 3 types, but in the US, the most common type is a cholesterol stone or white stones. It can happen in up to 20, depending on the study, but maybe 20% of us are walking around. So, you know, a good portion of us here, we probably have 8 or 10 of us in the room that have gallstones. And most of you who have them will live your life and never be bothered, right? You'll go all the way to the grave, hopefully at an old age, and they will have never caused a problem. But maybe 20% of the 20% end up having an attack or a problem from a stone. It can plug up that cystic duct, so it can get stuck right where the gallbladder is trying to empty, or it can get stuck down the common bile duct, or it can get stuck right down at the bottom. And interestingly, the pancreas also, the main duct of the pancreas, joins together with the common bile duct right before they enter. So if the stone gets stuck at the bottom, you can kind of tick off 2 body systems. The pancreas and the liver can kind of get all inflamed at the same time. We can also get polyps, which are abnormal growths, but not necessarily a cancer in the gallbladder that can cause symptoms, or you can get gallbladder cancer in a number of other things. There's lots of disease processes that can happen, but definitely number 1 is the gallstones. So what are you going to feel? You're going to have right upper quadrant pain. That pain is going to radiate to your back maybe, or up to your shoulder. We think that's because it's irritating the diaphragm. The diaphragm's nerves come from cervical levels 3, 4, 5, so it's kind of interesting that something in your belly hurts up in your shoulder, but that is a common complaint for people with gallbladder stuff. And it's usually postprandial or after you eat, and so people will have that symptom, not immediately, but maybe an hour after having their meal, and it lasts for a few hours and then goes away. If it starts causing nausea, vomiting, fever, it might be that that's not resolving and you've got an infection in the gallbladder that is going to be more urgent for surgical intervention. We're going to work it up, physical exam, so we're going to feel your belly. If you have tenderness in the right upper quadrant, and it hurts especially when you take a deep breath, kind of pushing that gallbladder against our hand, that's going to give us a hint that that's what's going on, because the belly is a little bit of a black box. There's like a lot that can go wrong when you come in with belly pain, or be going on when you come in with belly pain, so it takes a little bit to figure it out. Get some basic labs and blood work, looking at the liver, looking at the pancreas, and looking at your blood count to see, do you have evidence of infection or irritation of those other organs? And then get imaging. And the imaging, luckily for this, is really pretty quick and cheap, ultrasound. And so it's the best test to look at the gallbladder. It can see 95% of stones if they're going to be there. CT scan is actually not the best test for gallbladder, so it's nice that this one, quick, cheap, and no radiation exposure to get it done. Sometimes, though, it's not conclusive, and still we have to do other tests. We end up getting either a HIDA scan, which is a nuclear medicine study, CT scans, or MRIs to try to figure out what's going on with the bile duct and gallbladder. So the first, even before the first line there of taking out a gallbladder, which is a cholecystectomy, but before we did that, we actually just said, hey, you got stones, you got a problem, let's go get rid of the stones. Kind of like the same theory of kidney stones, where you go take out the stone, but you don't deal with the actual kidney. Right? We don't take out the kidney when we deal with those. But it turns out this is different, that if you take out the stones and sew up the gallbladder, people just recreate stones, they have a problem again in the future. And then the reoperative risk is really high because the biliary tree has a real inflammatory response. The second operation is hard. It's a real challenge, and it's dangerous for the patient. So the first cholecystectomy was 1882, and that really became the standard of care for 100 years or so. And then Dr. Sem is a German surgeon living from in the early 1900s to 2003. And he was the guy who figured out laparoscopy. And so he was using it in gynecology, looking for ectopic pregnancies, looking at ovarian cysts, trying to figure out pelvic pain in females was like the first couple of reasons that he was using it and looking. And it was hard. Like, they didn't have nice fiber optic lights, and so trying to hold a flashlight through a little lens and look in, and nobody else can see what you're looking at. And they didn't have insufflators to inflate the abdomen and hold the abdominal wall up back then, so they're doing that manually. So you got assistants kind of pulling up on the abdominal wall while you're looking in there. But anyway, so he figured out laparoscopy in the 1960s, and then the first laparoscopic cholecystectomy was not that long ago, 85. And it's pretty crazy that, I mean, from 85 to now, you know, so 40 years, it's the #1 procedure done in the country. And so that's pretty crazy that it's just gone. So the old incision was a right upper quadrant incision, and a lot of people still have that scar walking around. And we occasionally still have to make that scar. So I don't want to totally dog, like I talked about, Dr. Cogbill, saying if you need it, you do it, right? But now it's most often a 4-port laparoscopic surgery. And it's pretty amazing how things have changed because of this, right? So, oh yeah, here's the video. So this, I'll just talk a little bit before we push play, but is a short clip of kind of what it is like to do laparoscopy. So we're starting looking at the center of a port here. The black is the middle. So we're going to drive a camera down the port, and then it'll look over to the left a little bit. You'll see what the inside of a laparoscopic port looks like, but then we'll start talking about liver. So yeah, go ahead. And this is just a minute and a half. It's not super long. So we're going in. Those are my instruments reaching in, and I'm holding up underneath the liver, and that's the gallbladder, and grabbing that, retracting up towards the right upper quadrant, towards the diaphragm. And what I'm now touching is an abnormal adhesion or scar band of the omentum, which is a fat layer on the inside of all of us, kind of stuck to the gallbladder. And so this fat is not normally stuck here. And you'll have to take my word for it, but this adhesion is actually, it looks kind of chronic. It's not inflamed or, you know, swollen, not edematous. And so this is kind of chronic cholecystitis. This is a gallbladder that's been irritated and inflamed, and our body is really good at scarring stuff and holding it away to protect other parts of us. And so this is what it does. When the gallbladder is infected, it does it. And it's pulling in other organs. So you got the duodenum, or the stomach is just over here, and then the beginning of the small intestine is kind of looping up towards the gallbladder. And so when we talk about adhesions, this is kind of what we mean, and I'll talk later about like post-operative adhesions and scar from our incisions. And so you can imagine this kind of stuff stuck to the abdominal wall or stuck around to other things. That's what we mean when we're talking about, yeah, scar tissue adhesions forming. This is a normal, healthy-looking liver, maybe a little bit fatty, so the edges are typically kind of right angle sharp in somebody who's not overweight. And as we gain weight, we put it everywhere, right? Upper arms, legs, in our belly, and then in our liver. And so it kind of swells and it gets kind of rounded edges. So the stereotypical person we say is, kind of in their 40s, overweight, fertile, and female. That's the stereotypical gallbladder attack. But really, anybody. I mean, I think my youngest gallbladder I removed was an 11-year-old kid. And the oldest is in their 90s, and male, female, everybody. And so, anyway, so that's that. So yeah, it started in 85, it's taken over. The recovery is unbelievably faster. So the old tradition, open cholecystectomy, people were in the hospital for 5 to 7 days, not eating for a couple days usually, slow resolution of diet and bowel function, and then pain control was a challenge. And the recovery to physical activity was more challenging because you're going through the rectus muscles, the oblique muscles, and so you might have weakness. They can get denervated. You can have hernias and abdominal wall bulging because of the incision that was made, and so that can all make recovery harder. Laparoscopy, if it's a planned surgery, you might be with us for a total of 3 hours. You come in, you get your IV, you put on a gown, we put you to sleep, takes an hour, you wake up and you're home. And some of that was driven by providers and patients, but honestly, a lot of those kinds of changes were made by insurance pushing, saying, you know what, they don't need to be in the hospital, they're gonna do okay, we're not gonna pay you to keep them, so send them home. Well, that actually worked out well in that case. It doesn't always work out that well, for everybody. But sometimes the payers see the trends and people are hard to change. It's hard to, to old dogs, new tricks. So anyway, so less hospital time, good time to return to work. When we make smaller holes, you're less likely to get an infection, right? Smaller wound, easier to heal. So that has happened with this. Less pain. And then we think that, big cuts create lots of scar tissue. And we tell people that after a laparotomy or a big wound that maybe 5% of people in their lifetime will have a bowel blockage or a bowel obstruction from the scar tissue that forms after a surgery. And we think that's considerably less with laparoscopic surgery. So that's a good thing because those are not fun to have if you've ever had one. So open surgery really electively is probably the second choice or third choice these days. But I don't want to totally poo-poo it because if you say, hey, I just had an open cholecystectomy last week, there are reasons we do it. So it still happens, but we'd like to do smaller cuts if we can. And sometimes one of those examples would be concurrent operations. So people that are having, part of their pancreas removed for tumors or frequently have gallbladder removed at the same time, and that's a lot of times done through open incision still, but although that's shifting now that we have robot, and we'll talk about that. But that's just an example. And then single incision. So for gallbladder, single incision surgery was really taken off while I was in residency. So we were doing a few of those. And our experience was what the data has shown kind of nationally. And that was that people came in asking for it mostly for cosmetic reasons. They didn't want to have a scar. So if you could do it all through their belly button and hide the scar, then they were happy about that. It is feasible. It did take longer, but probably longer because of learning curve, right? Anytime you do a new technique, same procedure but a little different, it takes time for surgeons and the team to get good at it. But we definitely had higher wound complication rates, meaning infections, and then post-op hernias at the umbilicus because you're making a bigger stretched hole to fit 4 things through one spot. And the recovery actually wasn't any better. People didn't heal faster, feel better, the pain wasn't any less. And so it's kind of fallen off favor, except for the few that, really don't want a scar. They say, hey, I'll take that hernia risk if you'll do it so I don't have a scar. And then robot we'll get into again too, but robotic surgery is really just an extension of laparoscopy in the fact that we're using the same kind of ports, similar instruments, although there's some real advantages to robotic instruments. And the optics are slightly improved because you have a little bit fancier camera with, although they're really close together, you do have 2 lenses, and so you have a little bit more depth perception with robotic surgery, which is kind of nice to help give that feedback to you. So this is a study from 2014. It's a meta-analysis, so it's putting all the studies together that were available at that time, looking at surgery in the elderly. Sorry that that's defined as 65. But it's talking about laparoscopic versus open. So it's interesting still, only 11 years ago, there's a debate, is this better than open surgery, right? So not that long ago that they're still talking about it. Let's see if it'll go forward. There it goes. So when we looked at the 300 studies, or 13 articles, the mortality was better. It was 1% looking at laparoscopic surgery versus 4% in open. The morbidity, so that's a catch-all term in medicine for any problem that can happen. That's a wound infection, pneumonia, MI, pulmonary embolism. It all goes into that. So that's kind of a good term to know, like, what's the overall risk that I'm going to have a problem happen. So if you ever want to look that up when you're getting ready to have something done, that's a good term to know. There's a, in this case, 11% chance with laparoscopic surgery that you would have something that we would consider a complication or adverse response happen versus an open surgery of 21%. Cardiac complications, 0.6 versus 1.2, so low risk either way, but it was half the risk if you did it laparoscopic. Respiratory complications, again, about half, 2.8 versus 5. And so they concluded that there was a trend towards improved outcomes with laparoscopic surgery for working on the elderly. So this is for laparoscopic versus open for symptomatic cholecystolithiasis. So this is not infected gallbladders, but it's stones that are causing pain when you eat. And this is done 2006. And this was more inclusive for all age groups. And this was similar that, but this is also earlier in the curve of when laparoscopy was happening, right? So it's only been going on in this study for like 20 years because it started in 85 to 2006, so 21 years. But there were less overall complications. There was no difference in mortality, and there was shorter hospital stay in laparoscopic cholecystectomy. And so this study, was early in the series, and it had a lot of people, but it was a good, I think, important time frame just to say that, you know what, this is safe. Let's continue studying it, right? Because at some point, early on, you want to know, are we hurting people or not? If you're hurting people, you got to quit. If it's just taking longer to do it because you got to learn how to do it faster, then maybe you can keep going. So I think that's kind of what this study said, was that they're equivalent at least. Let's keep studying. Okay. So we're going to talk about the appendix. Again, a little bit of med school. The appendix is a piece of intestine. It's small. It's about Bic pen diameter and maybe as long as your index finger in some people, or pinky finger. We don't think it really has a use. There's a lot of cool theories out there for what it may be. The theory I like, and that I tell you and I tell all my patients when I'm meeting them, is that I think that the idea that when you have a diarrheal illness and you clean out yourself, right? You get a virus and you just have diarrhea for a few days. You need to recolonize the gut flora to get back to basic life. The idea is that this is kind of just a pocket where bacteria aren't going to get flushed necessarily, and they can help to recolonize your gut flora kind of thing. But nonetheless, if you take it out, people don't really have any side effects. So we're not really sure what it's there for, what it's doing. It's in the right lower quadrant typically, although there's all kinds of anatomic abnormalities that or differences, maybe not abnormal, but differences that can happen with development and embryology. So it can end up in any quadrant of the abdominal cavity. But typically, someone who gets it is in their 20s and 30s. But again, I've taken it out in 3-year-olds and into 90-year-olds. 8% of us in our lifetime will have it, so this is the most common emergency operation we do. The gallbladder is the most common operation we do, but this is ER. And the most common cause is lymphoid hyperplasia. So our gut is next to our skin, it's like kind of the second biggest organ that helps us defend against the environment, right? You're putting insults into it every day, bacteria, viruses, whatever you're eating, ingesting, swallowing, and our gut is the first defense to that. And so there's a lot of reactive autoimmune cells in our gut, and there's a pocket of them sitting right around the appendix. And so it's actually pretty common after an illness kind of comes through town, a week later, we'll get a run of appendicitis at the hospital. And it just seems like the gut system has revved up and it kind of swells the opening of the appendix shut, and then here comes appendicitis. But there are lots of other causes. You can get a polyp in the appendix that plugs it up and causes the problem. You get an actual tumor, different kinds of tumors. It can be lymphomas or carcinoids or adenocarcinomas. Inflammatory bowel disease can cause inflammation. So lots of different things can make appendicitis. And foreign bodies. I've got cool x-rays of people, especially people who here in Alaska, well, probably anywhere who eat bird, but a lot of people eat waterfowl and shooting with shotguns and then ingesting pellets, not knowing it, and they'll end up in the appendix. So you get an x-ray that shows a pretty cool outline of an appendix full of BBs. So you come in, usually you have abdominal pain. the most typical description is like, hey, it started off diffuse, it was kind of everywhere, and then over the next few hours or day, it moved to the right lower quadrant and became more focal. It is usually worse when you're moving, when you're walking. So if I usually ask people, hey, on the ride in on the road, which is not smooth, I know it's not, did the bumps hurt? And if they did, then that might be a hint that you got something like this going on. It's better when you're resting and not moving. And the pain comes before the pukes. So if the pukes came first, it's rarely appendicitis. But if the pain came first, it might be. We're going to, again, do a physical, do labs, and then do imaging. The imaging this time is CT scan is the best. So in the old days, before we had CAT scan, surgeons were told that they were only supposed to be right when they were good about 80% of the time with the diagnosis of appendicitis. So it was acceptable to go to the operating room and not find appendicitis 20% of the time, which is kind of mind-boggling that you went for the wrong operation, didn't find the problem a lot of times, 20% of the time. So with CT scan, we're like 95 to 98% accurate. So we're still not 100%, but CT scan is pretty darn good at saying, there's the problem, that's the problem, let's go fix it. Sometimes we have to use other tests to do it, and sometimes there's a reason to use a different test. So if you come in and you're in your first trimester pregnant, we don't want to scan the baby with radiation, and so that would be somebody who might get an MRI to try to figure out the diagnosis. And if you're a kid, you don't necessarily need an MRI because they're really claustrophobic and they take forever to get done. So try to hold a 2-year-old in an MRI scanner, that's not going to happen. But you also don't want to radiate a kid, and so an ultrasound would be acceptable in that case to try to find appendicitis if you can. So again, there's reasons that you might get a different test, but the average adult's going to get a CT. So the first appendectomies or removal of the appendix were like 1731, 1735. Dr. Amiand, this is one of those, a couple dead surgeons, but Dr. Amiand was pretty neat that his first appendectomy was a case like this. And so we're all pimped in surgery residency for what it's called when an appendix shows up in an inguinal hernia. So he actually was going to do an inguinal hernia surgery and found an appendix, and that's when he took out the first one. So that was kind of neat. And I guess I'll just take 2 seconds to say this is what a lot of people have never seen a CAT scan. So this is a CAT scan image. We look at it and we can look in different views. So the big picture is you standing up. We call this a coronal cut, like you are wearing a crown. Kind of that's the angle of the cut. And then we can change the thickness of how often we look with the machine. So we can look every 1 millimeter, 3 millimeters, 5 millimeters, so we can look really fine detail or not. And so this is a liver in the abdomen. This is large bowel with air inside of it, so it's black. Everything outside everything air is black. Bone is really dense, so it's bright. So this is the iliac wings, iliac crest. So that's kind of what we're looking at when we're looking at a CT scan. So the traditional incision is the McBurney incision. So it's a right lower quadrant oblique cut. And it's usually 1 inch to 2, depending on how thick you are. We usually tend to think for an appendectomy, now this doesn't work for all kinds of surgeries, but for an appendectomy, we have to make the incision as long as you are thick for us to be able to see what we're doing inside of there. Well, that's then going to translate to, laparoscopy is lots of 3 small cuts, Bic pen sized, and those don't change size depending on how thick you are. So you can imagine that with the way the obesity epidemic is happening, that some people would need a really big cut to see the appendix, to get down there and do what we need to do. And that's a huge advantage to laparoscopy, that we can get a lot done through the same small cuts, and that helps to decrease the morbidity for the patients. So, again, shorter hospital stay, even when they're infected. If they're not ruptured, and there's not poop all over in the belly or pus, if it's just early appendicitis, this is a same-day procedure too. I meet you in the ER at 7 p.m. Hopefully the OR is available. We get up there by 8 and do it, and you're leaving the recovery room by 9, 9:30. And so that's pretty neat that has really changed. And you'll see some studies that are pretty remarkable for what the lengths of stay used to be. Less pain, fewer bowel obstructions, the same kind of deal. So this is a study from 2009, not that long ago, with laparoscopic appendectomy. This was done in Asia, and this is just a good example of how stuff has changed from then till now, which is not that many years. So this is looking at people 14 years and older from just years 2006 through 2007. And it said that operating time was shorter for open, but barely. So they were still learning how to do laparoscopy. It took half an hour for laparoscopy, 28.7 minutes for open surgery. But the hospital length of stay was 4 days for laparoscopy and 7 days for open. And so from just then till now we're down to hours instead of days. General diet, they didn't get to eat for 20 hours after laparoscopy and 36 hours for open surgery. We feed you and pack you now. You wake up and we hand you stuff and say, hey, enjoy this. And that does two things, or more than two things. One, patients satisfied, right? Because they usually weren't allowed to eat before surgery, so they're hungry. They woke up and they're hungry. Two, we think you need nutrition to heal. So getting people that nutrition earlier helps to speed that recovery and improve outcomes as far as that's concerned. And we think that oral stimulation actually gets the gut working. So when we were waiting for people to poop before we fed them, we were actually causing the problem by not feeding them, you know? So if you just put something in, something will come out. So all that helps. Wound infections were more common after open surgery, this showed. But there's a little caveat that for whatever reason, well, it makes sense with the skin, that the smaller cuts on the skin, laparoscopy has less infections. But for ruptured appendicitis, when it's poopy on the inside, it is really hard to wash out laparoscopically. The gut, if you've ever looked inside of an animal or a fish when you're cleaning it, right, things are just sliding all over each other, and if you try to wash it, the fluid's gonna go behind the next loop of bowel or behind the next organ, and it's hard to collect all the water that you put in there. And so intra-abdominal abscesses are actually higher after laparoscopic surgery, especially in the contaminated cases, because it's just hard for us with the tools we've got currently to wash it and get that stuff out of there. Yeah, I think. So for comparing outcomes between laparoscopic and robotic appendectomy, so again, we'll talk more about what the robot is in the future, a few slides, but this is a NISQIP database, so using that same quality database nationwide, so it's a huge number of patients. They're looking at that robotic had longer medium operative time, but that's probably an example of, again, people learning a new skill, new tool. But shorter post-operative stay. So they showed 0.7 days versus 1.3 days if you use the robot. Everything else was pretty equivalent. So the p-values were not significant for the other days, except, and I didn't circle it, sorry, but this study showed that the mortality, the 30-day mortality, was significantly higher in the robot. They did not talk a lot about why they thought that was, what happened. I don't think it's related to this tool, but and then, what was the other point I was going to make on this one? Oh, that I don't know how they didn't talk in the study about how they were diagnosing them, but only 50% of people had actual appendicitis on pathology. So they took out half of the appendices for not appendicitis. So the most minimally invasive thing that's kind of cool about appendicitis is, do you need surgery? And so I used to tell people in the ER, maybe during residency, that across the pond over in Europe, they would offer you antibiotics alone. And they had some really cool early data. So I was in residency 2011 through 2016. And the initial studies said that 80 to 85% of people could be cured of appendicitis with antibiotics alone, not needing surgery. And so and the initial studies only looked at it average age adults, so 18 to 65. They didn't look at the elderly and they didn't look at the young. So we couldn't apply that data to kids or to people over 65 initially. Now they've done more studies and it shows that it probably is the same in those ages as well, but maybe not quite as good as we thought. So the punchline is that appendicitis is, if it's early, not ruptured, and it's not due to mechanical blockage. So on some CT scans, we can see that there's a poop stone or fecalith in the base of the appendix. Those fail antibiotic alone management. And if they already have an abscess or a rupture, it's too far gone. You've got to go do something about it. But if it's early appendicitis with no mechanical blockage, most people, definitely more than half, but probably between 65 to 80% of people, will resolve and do better. And so that's a cool tool for a few reasons. One, it's way cheaper, right? To say, here's some augmentin you can leave instead of, hey, let's go to the operating room and do appendicitis or appendectomy. So definitely people, I have this conversation with everybody. If they don't have insurance, they're going to choose the antibiotics. I almost guarantee it, right? Like it's $20 versus a lot. But also people who have other problems that might make them really high risk for surgery. So we just did this, people who are post-MI. So they had a heart attack last week, and now they're here with appendicitis, so they're on blood thinners, they have a new stent, they are high risk to sedate. You might give them another heart attack or a stroke. That's a good person to do antibiotics and then wait maybe 6 months or a year till you do an appendectomy if they still need to have it done. So those people have that option. And then people who just want to. They say, you know what? I don't want the risk associated with surgery. So this is definitely minimally invasive. The recurrence rates move a lot with the studies too. So it says that antibiotic alone fails in 8% of people within the first 30 days. So, and then 20% of people, if they succeeded, will be back with appendicitis within a year. And at 2 years, that might be as high as 50%. So it probably is there's a good chance you'll end up coming back to talk about having it out a second time, but you definitely can get through the first attack with antibiotics. Not definitely, most likely can get through it. So this kind of says that. I guess I could have been showing the slide, but I just told you what the slide said. So robotic surgery. So again, the robot looks like this. We talked a little bit about how it is laparoscopic assisted surgery. So we start at the patient bedside with the surgeon, the scrub tech, everybody, we're scrubbed in, sterile. We put the ports in the patient. We bring in the robot, and so the robot it's on this boom. It has 4 arms. You can use up to all 4 of them, but you don't have to use all 4. You can hook up just 3 if you want, or 2. And then once it's docked, then the surgeon leaves, stays in the same room so you can communicate, talk to your team, know what's going on, but controls it from another kind of console over here. And it has foot controls and hand controls that you kind of get used to the dance of kicking your left toe left and stepping on your right toe and moving your right hand to make it do a command kind of thing. And the real benefit to this is, first, the ability of the tools. The old laparoscopic instruments are, like we said, straight sticks. So you got all kinds of different tips. You can get kind of different tools and scissors and grabbers. We got energy devices. We can coagulate blood vessels. We can staple off things to seal and cut at the same time. But you can't reach behind something. And so the robot gives us that. It gives us flexion, it gives us abduction, and the ability to close. So you can get on the back side of a round organ and do something, which is pretty cool. And you're doing it while you're sitting looking comfortable instead of looking like this guy, right? Got the chicken wing out, you're leaning over the patient and trying to do the operation, and after an hour and a half of that, anybody would have back pain, shoulder pain, right? And then you do it for a career, people quit operating because they hurt. And so we think that the longevity of the surgeon is better with this, but that also, I think, translates to better care for the patient and the fact that you're not uncomfortable and rushing because you want to be done. You're comfortable doing what you want to do, so you'll take your time to finish it, kind of thing. So are there outcome differences? Similar to the laparoscopic trends that we talked about before, that when we are learning a new skill, it takes longer. That is definitely true with the robot right now. And so we've got a lot of studies that show, this is a meta-analysis again from 2017, so not that many years ago. And it showed that median operative time was, a little bit longer doing robotic surgery, 128 versus 115 minutes. But the intraoperative complication rates were no different. They were 0.5, so totally equal. Conversion rates trended towards a little bit lower, but they weren't significantly. It was, p-value 0.06. So, but there was a trend towards the robot keeping people laparoscopic versus needing to convert to an open incision. And blood loss and complications were no different. Duration of hospital stay was no different. So this early study, I think, shows that robotic surgery is safe. The risk profile is the same. It takes a little bit longer. We may see benefits as the learning curve continues to go. And similar study. For appendectomy, the notable difference in the time really here, and so robotic, and then we already talked about this study too, that it was longer time, and this is the one where they only had 50% of people with appendicitis when they took it out with the robot. So these are kind of cool where we're going now. So general surgery in Fairbanks, Alaska, that can mean different things in different places, but the bigger cases, that is our average bigger case, is probably colectomy. So taking out the colon for diverticulitis or colon cancer. We do others, big surgeries too, but that's kind of the more common big case that we do. And it has some real associated morbidity and mortality, mostly morbidity though, with it. The first thing is you're working on the colon. It's not sterile, and so wound infection rates are a real deal when dealing with colon. And that can range statistically from 5 to 15% probably, and those infections can happen down in the belly or in the abdominal wall. And the main risk of an infection, because we can usually fix it, right? You can open the wound, you can drain the pus, you can get it to heal eventually, or if it's an abscess on the inside, we can put a drain in it to get the pus out and you heal. But it's definitely inconvenient for the patient to deal with a post-op infection, and that really increases the chance that you have a hernia at the site where the infection happened, because the fascia does not heal well. So that's the real, shucks, when an infection happens, we're almost guaranteed to get a hernia in the future that we got to fix. So it's another operation someday. And so that's something that we watch on our NISQIP, right? We look at our own infection rates as we're doing these, and then it's a moving target always. We just released a new bundle at our last surgery meeting that we're going to do to try to improve this even more. But this robotic surgery has really improved the ability to do intracorporeal anastomosis, so hooking the bowel back together because of that dexterity that it gives us. So we used to really utilize at least a mini laparotomy, so a 5 to 8 centimeter incision to reconnect the bowel ends, but now we might not have to have that as a reason for doing it. And so we actually, they're pushing towards doing transrectal removal of the specimen so that you don't have to make a cut. And so, traditional laparotomy, this is kind of what we've been doing for the last 10 years, so multiple laparoscopic ports and then an extraction site where you're bringing out the piece of colon through. Now we're hoping to do this. So you get 4 or 5 laparoscopic incisions and no big cut, because you can do this. You can cut out the part of the colon that's the problem. You can put a little sleeve up the anus. You can pull out the specimen through the anus, and then you can sew the ends back together without ever having to make a hole inside. And so that's pretty cool. It's still not a big exit to get stuff out through, right? And so some things, this isn't gonna work still. People unfortunately get big tumors that we have to get out, and so you're gonna need to make a bigger hole to get those things out. Or diverticular colons can be unbelievably scarred. So diverticulitis is an infectious process of these little weak pockets in the colon, and they can sometimes be just really woody and inflamed, and then I think that can be hard to get out. But there are plenty of cases where this is working, and so I have not done this yet, but I think it's pretty cool what they're doing. Breast surgery is really common. We do a lot of this up here in Fairbanks. To be brief, because I think we almost used up the hour here, but radical mastectomy is the old traditional take off the whole breast and the pectoralis muscle, so pretty morbid and weakness and lots of side effects for the patients having that done. So then modified radical mastectomy is just removal of the breast tissue but not the muscle wall of the chest, and that was a huge improvement but still a big deal to lose a whole breast. So in the last couple decades, lumpectomy, which is removal of the part of the breast with the tumor but leaving the majority of the breast, has been considered minimally invasive. That was kind of the newest, latest, greatest, and that is the most common procedure done for breast cancer these days. Although there has been a little bit of a swing back towards mastectomy, probably because of the ability of plastic surgery. So we can do a lot of reconstructed things these days, and so people are thinking, okay, but lumpectomy has been the MIS version of breast surgery. But again, driven by the sick, who are not good operative candidates, we don't want to put to sleep. And because of technology advances, we're now doing this kind of thing. So we can, for small tumors, so tumors that are like 2 centimeters and less is kind of what we're thinking about for this right now. You can do it percutaneously with a needle. So you can put a needle into the tumor. You can either do cryotherapy, so freeze it, or you can do radiofrequency ablation, so you can kind of fry it like with a microwave, you know. But it's they're programmed, they are tested to know where the kill zone is going to happen around these devices that we're putting in. And so you can treat a tumor through a needle poke. So I think that this is all still testing. It was just talked about at a Mayo meeting I was at in February, but it's all like under study. It is not broad spectrum yet. But I think that this is definitely going to catch on and be something that will be good for everybody. I think to have less scar, easier recovery, that kind of thing. So MIS will change. What we mean by it will change as the technology advances, and then we get to do it. It's a learning curve. It takes a while for everyone to get good at it, but to do it in a safe way. So you got to make sure that you don't jump on things too quickly. And thank you very much. I would love to entertain questions. Yeah.
Questions?
Antibiotics, what are you guys seeing for continued effectiveness, new antibiotics? Are you seeing hurdles there as far as the antibiotics goes, or is the antibiotic industry able to keep up, with all these other changes?
Yeah, I think that's a really good question. Antibiotics are, for the most part today in Fairbanks, Alaska, doing fine, keeping up. We haven't had super resistance noted up here, but it's always a moving target where, like the beginning of my med school training, MRSA, methicillin-resistant staph, was a big deal. It was a fear that it was going to be just super bug gone in 2 or 3 years, right? Well, that hasn't happened. They've kept antibiotics going, and we can take care of MRSA still. And then there's kind of 3 other big bugs that we don't want to have that are tracked by the hospital, and we might get 1 or 2 per year that come up, but so far they still are treatable, but it's a challenge sometimes.
Questions? And the mic will help us pick it up for the video.
I'm just curious if that technique you showed right at the end with the needle and the freezing on the breast, can that be done in other organs? Yeah,
good question. So it's been used more in kidney and liver, and so it's only recently been expanded to breast. But radiofrequency ablation and cryoablation have been used in other organs. Yep.
More questions?
I got a couple that I'll try one to see if somebody else has a question. About 20, 30 years ago, when I could not see my medical records here in Fairbanks, the hospital wouldn't let me look at them, they said, send me a doctor or whatever. And I made 25 trips to Peru, about 5 months each. So I started getting my physicals for a short time in Lima, Peru. And they had 12 million people, huge hospitals and all that. And one thing I did 3 years in a row is and I got a DVD and a hard copy of everything. They took CAT scans and they just segmented me. So I took the scans, enhanced every one of them, turned them into a movie. So I could move in and out of my gut, which is kind of weird. And I gave it to I was at a clinic that had, in Lima, 500,000 patients. And I showed this to one of the main doctors. Where'd you get the machine? I said, the laptop. And he said, how can we do this? I said, go find a 17-year-old.
Yeah.
But what I want is, if I could do this 20 years ago, can we get high resolution, forget the legs and the arm, gut. And then, I guess the science is moving towards AI, can work a lot faster. Could we take gut movies and look for anomalies? And so, you know what you're looking at before you poke a hole.
Yeah, I think so. Hopefully I'll answer the question with what you mean, but we do have the technology that this looks like a movie when I'm looking at your CT images right now. So I mean, it's real-time scrolling through it, but it's moving and doing things. And we do CT enterography to look for like colon polyps. So that is, in people, it's not as good yet, but it probably will get better. Well, it will, not probably, it will get better with time as technology improves and the data quality improves, but as colonoscopy, so we still think that we find more polyps with colonoscopy than we do with CT enterography, but there's some people who we can't get through their colon because it's twisty, it's turny, they've got whatever anatomy that we can't get through it, so we use that video CT enterography to look at their gut. It's still, there's room to grow for sure. It's not perfect, and I'm not a radiologist, so that'd be best to let them speak to, but yeah, we have it, and it's pretty cool.
I was just wondering, it's quite impressive, you know, what you're telling us, and you're keeping up, but this is, you know, FMH. Can Fairbanks, 1,000 miles away, because of today's world and the internet and all that, keep up? Or is our community, our medical community, taking care of this and doing the best it can? Kind of not a dumb question, but there's so many things you have to do, and there's only so many people to do it. So I was just wondering what your thoughts are and whether we're keeping up.
Yeah, no, it's a really good question, and it's a hard answer because it is hard to keep docs in town. I imagine many of you have lost a PCP recently, or trying to get one, or trying to get seen, and it's a 6 or 8 month wait. You want to get a surgery, and you know, right now I'm booking to middle August, right? So that's a wait for people, and whatever. So it's like, yes, is the answer that it's painful. Are we keeping up? Yes, but man, you got to be active and proactive as a provider and as a group of, you know, the foundation, trying to keep moving in the right direction. And I think that it's easy to become lackadaisical and to just do what you do, and because it's hard to keep learning and getting better. So we got to try to fight that. And I do think that we have a really good group of docs in town that are really trying to do that. And then as the system, you know, they're getting the latest, greatest frequently. So they're putting the money in. It's not always a money-winning venture. They lose money to do the right thing. At least I've only briefly been employed by FHP. I was at, you know, the Native Health System for the last 9 years. But both entities have been trying to do what's right, I think, for their patients. And so they're really trying to do that. And we're doing a huge electronic health record with AI upgrade that's supposed to go live June of 26. So we got 1 year from today that it's supposed to, hopefully, it'll be great. Be a new EHR that's supposed to make our job better as docs, but also make it better for you, the patient. So it's supposed to be listening to us while we're talking to you, and we go, hey, I wonder when your last colonoscopy was, and it's supposed to pull it up and say, hey, we found it, here it is, rather than taking time to go look for it, right? It's supposed to just show it to you. And then it's supposed to prompt you to do stuff that you might have missed, right? Hey, the A1C is elevated, your glucose or your sugar is not well controlled, let's improve your diabetic control. Now, it could be really obnoxious and horrible if it's not done right. It could be a huge, powerful tool because we're all humans, right? We're going to make mistakes. So you should use the computer to its maximum, realizing that it's still just a tool that's only as good as the programmer that put in the data. And so, I don't know if that answered your question, but.
Yep. We'll do our best.
Yeah. And I'd like to keep it on time, so I don't want to catch another question. But next week, Dr. Heffington, Medical Director at FMH, and Kari Burrell, Chief Strategy Officer. This is what it's all about. And that is an excellent question and a great question for Dr. Heffington next week, if you could. But let's get if you don't mind, one or two more.
I have a question.
Great.
Okay, mine are absolutely silly. One is, do you remember your patient's name?
Yeah, most of the time, but usually it's a face and a disease, not a name. So I can look at somebody and go, yeah.
Well, showed her. And obviously, I don't know if you remember, but you removed my spleen last year, so. And I know, like, patient privacy, you weren't gonna say anything, but I think it's kind of cool. I'm always willing to show people a scar whenever they ask, but thank you for this. This helped me overcome a bunch of anxiety. And I just had this moment where I was like, you have seen parts of me that nobody else has. I was like, I just want to go learn more about this. I don't think that what happened to me was, I think you tried to be minimally invasive, but I fall into the category of you had to cut more to get my spleen out. So my only other silly question is, do you like listen to anything while you're in the surgery? So a lot of things popped up after you did surgery. I mean, like, do we listen to music or what was a podcast maybe? Sorry, I just maybe I'll like end this like lightheartedly.
There you go. Yeah. No, thanks for saying hi and bring that up. But yeah, I listened to, you probably either heard Billy Joel or Elton John or Jason Mraz. I don't know. Those are who I would be listening to in the OR. Yeah. So yeah.
One last question. Okay.
Oh, I just
Excellent.
have a comment.
Great.
Being a nurse, what do the nurses do nowadays? You don't need a circulating nurse?
Oh, we definitely do.
Do you?
Oh yeah. Oh, totally. No, they're running all the time.
Well, think of the instruments you don't need, because you've got everything on your robot.
Well, no, but it's still each arm gets an instrument, yeah, and so they're going to get it, bringing it in, yep. So they're running all the time, and it wouldn't happen without a good scrub and a good circulator. Yep, they run the room. Yep. Mm-hmm.
So a big hand for Dr. Tsigonis for that critical reputation.